All right, it's 2 minutes after, and as
Recording in progress.
more individuals will be coming in, I'll just make some introductions so we're all familiar with each other. I'm Dino Spagnolas. I'm a professor of surgery at Stony Brook University and director of the bariatric program in the foregut surgery and bariatric surgery division. I am joined by my two co-moderators, Dr. John Hunter, who's a professor of surgery in the division of bariatric surgery at Oregon, OHSU in Oregon. Previously served as a professor and chair of surgery, as well as executive vice president and CEO for the health system. Dr. Hunter has an extensive experience in foregut surgery, published more than 300 publications in this field. Previously chair of the American Board of Surgery, and really a pioneer in the advancement of modern foregut surgery. Professor Theodorou, who's also a moderator and on the call, is a professor of surgery at the University of Athens, where he's a chair for the first department of surgery, and a distinguished specialist in upper GI laparoscopic surgery. Also has extensive contributions to the field and clinical research for motility and GERD, and most recently served as the president for the, I think, European Foregut Society, where he's currently a board member. So thank you everyone for joining our discussion and webinar on GERD diagnosis and management. And we can start with our first presentation and then wrap it up at the end. After our three presentations, we'll wrap it up with a group discussion.
Thank you, Kostas. It is really a great honor for us and privilege to have this new series of webinars. And I would like to thank all colleagues from overseas for their efforts. I was lucky enough to have all my training and fellowship with Dr. Tom DeMister at USC. And I did learn everything about esophageal lab. So I did establish the first lab at the University of Athens, which is run by surgeons, me and Dr. Triadafilou, she's an assistant professor of surgery, and she runs the esophageal lab along with the upper GI surgery. She specializes, and she's gonna start with a talk on diagnosis of achalasia. What's new? Manometry, planimetry. There are many new things going on. And Tanya, we're looking forward to hearing you.
Thank you, Professor, for the kind introduction. It is my great pleasure and honor being with you today and being the first speaker out of a really exciting program of webinar series we are going to enjoy this year, endorsed by the SSAT in collaboration with the Greek Cypriot chapter. And although I'm a surgeon, I really enjoy and I'm really interested in the interpretation of the esophageal physiology testing. And then when it comes to achalasia, some of those cases may be having inconclusive reports. So we have additional testing there, the new technologies and modalities, high resolution manometry, and the new classifications and planimetry are always good surrogates in the troublesome cases. So let's explore an overview of the modern diagnostic pathways in achalasia. I have no disclosures really. And the goals of my presentation will be, first of all, for the younger colleagues to understand how a normal swallow in a manometric study would look like, to compare that with achalasia or achalasia-like syndromes, to define the three subtypes of achalasia and understand why we have to classify our patients into one of those three categories, to identify any achalasia variants, to understand the clinical entity of the esophagogastric junction outflow obstruction, which is a relatively new diagnosis, and to see how the help and value of planimetry through the application of the endoflip can really enlighten the difficult cases. So we are referring to those patients with suspected achalasia. We tend to classify and evaluate the frequency and severity of their symptoms, still based on the Eckhart score, which is a rather fast, handy, and quite reliable clinical tool. So it consists of four main domains, namely weight loss, dysphagia, retrosternal pain, and regurgitation. And we have decided that the threshold of 3 and above is an index of abnormal significance. So for those patients with a predominant symptom of worsening dysphagia, the first and key step to do when performing the diagnostic pathway is number 4, which has been reordered according to the algorithm, and that is a very thorough upper GI tract endoscopy. You want that because you want to exclude pseudoachalasia, meaning those conditions that can really mimic the symptoms of achalasia, but would rather be attributed to other mechanical obstructive causes, such as malignancies, tumors of the cardia of the stomach or the junction. And so, although you want to have these typical findings in your endoscopy with the esophageal rosette findings or the retained food or saliva within a rather distended esophageal lumen, you definitely want to have a retrograde view of the junction, and that would be after passing the scope through the junction and having a reverse view of the esophagogastric junction. And to go back to the algorithm, after having that excluded, you would probably run a time barium swallow test, and that would be the old gold standard, which has been replaced by the manometric studies nowadays. So in the current era, the reason why wanting to have the picture of the esophagram would rather be to have a good baseline, especially in those patients who are to undergo an intervention. And now I'm referring to those pictures. So the typical picture of an achalasia patient would be these called bird's beak or rat's tail, incomplete clearance of the esophageal lumen. You see a very distended diameter, a very large diameter, and this incomplete clearance through the junction. So this is the lower esophageal sphincter, which is the area in spasm, which is the mainstay of our disorder. And then you also want to assess the height of the contrast. So you would probably see this column of oral contrast being retained within the distended esophageal lumen. And sometimes we want to assess the anatomy of the distal esophagus and the junctional area, especially when we're planning to perform dilatations, for example. So you want to see whether you are dealing with a sigmoid esophagus with those awkward ankles, or even a mega esophagus and end-stage achalasia. And to go back, the last but most important step in our diagnostic pathway is the high-resolution manometry. And so these tracings, which were included in the conventional manometry, have been replaced by the high-resolution manometry. So back to the old times, what we would see would be in the lower esophageal sphincter area, we would see increased pressures. So imagine that this horizontal line is the axis of time, and the vertical one represents the pressures. So you see increased pressures throughout the tracings, and no signs of relaxation. So this wave here does never reach the zero at your axis. And throughout the esophageal body, in the old tracings, we would also see no propagation of the peristaltic wave, so we would end up with simultaneous waves throughout the esophageal body. But nowadays, we are all happy that these difficult to interpret waves have been replaced by a very user-friendly technology called the high resolution manometry that consists of a probe with 36 pressure sensors, 1 centimeter apart. You can see the probe here placed as a nasogastric tube. This is connected to a transducer to the respective software that will give us these known as Klaus plots. So these color contours represent different pressures. The procedure is a rather fast and easy to perform technique. Under local anesthetic, 5 to 10 minutes. We perform at least 10 wet swallows, and some additional testings we will see according to the Chicago classification. And we end up sometimes with a normal swallow. You can see the range of the colors representing different pressures, with the bluish colors being 0 or the very low end of our range, and red and purple colors are the elevated pressures. So from the top to the bottom of the picture, this is a nice illustration of a normal swallow. You see the zone of the upper esophageal sphincter represented here, and you also see a very brief time frame of relaxation where the bluish color is 0 pressure at the level of the sphincter, aiming to trigger the process of swallowing. So I want to draw your attention and remind you towards the younger colleagues in the audience that this is the skeletal muscle. This is a transition zone between the skeletal and the mixture of skeletal and smooth muscle of the esophagus, and the rest of it, the distal part, would represent the smooth muscle of the esophagus. So you have a very nice propagation of the peristaltic wave that is gradually increasing in pressure over time, aiming to clear the bolus. This is a wet swallow, to clear the bolus towards the stomach after passing the junction. So this zone here is a nice overlap of the crura impression, the phrenoesophageal membrane, which is the extension of the peritoneum, and also the lower esophageal sphincter that is expected to have a very nice relaxation in this area here before contraction to avoid any reflux. But this is not the case in achalasia, and according to the Chicago classification version 4, which was introduced in 2021, we have 3 different subtypes. The common characteristic among them is an elevated integration relaxation pressure, but what differs between them is the pattern of esophageal peristalsis when it comes to esophageal body reaction. And in achalasia type 1, we have 100% failed peristalsis. In achalasia type 2, we have 2 out of our 10 wet swallows with failed peristalsis and panesophageal pressurization. Achalasia subtype 3, 2 out of 10 contractions at least represent premature contraction. And why do we care to really classify our patients within different subtypes? This is a very nice illustration of the 3 of them. So absent peristalsis type 1, panesophageal pressurization, these columns throughout the whole length of the esophagus, and spastic contractions in type 3, which is the least common. So we do mind in which category our patient belongs, because we know that the predominant symptoms differ among the different subtypes. And we now have enough studies showing that dysphagia and the sensation of dysphagia may be more proximal in achalasia patients type 2 localized in the mid-esophagus, whereas type 1 and 3 most probably are related to dysphagia in the more distal part of the esophagus. And when it comes to retrosternal pain and odynophagia, type 3 is usually the most common subtype. And the other reason is, and you will hear that more in more details by the next speakers, that different subtypes respond in a different way in different treatment options. So it's not the same when it comes to Botox, pneumatic dilatation, or endoscopic or surgical myotomy. And the least satisfied patient after a surgical intervention seems to be the patient with achalasia type 3. And one reason behind that may be the sensation of chest pain, which is the predominant symptom of those. And you see in these diagrams that the chest pain presents the least impressive change after the Heller myotomy. And another thing that is of paramount importance when we compare the two versions of Chicago classification, we identify a discrete category called esophagogastric junction outflow obstruction, which was not present in the previous version. If I zoom in this category, we define those manometries by elevated integration relaxation pressure, increased intrabolus pressure, and also the difference compared to the typical achalasia findings is that we have some sort of preserved peristalsis, and the clinical significance of that category is quite frequently problematic. And the algorithm here suggests we run additional testing in different positions, including supine and upright position during high-resolution manometry. And we also benefit from also performing esophagram or a planimetry test, and we'll see that in details later on. So currently, 1 out of 10 of our reports is indicating that we are dealing with esophagogastric junction outflow obstruction. And the reason why continuing to investigate those patients would be for that subcategory complaining of dysphagia or less commonly retrosternal pain. So the pattern is in esophageal body peristalsis may vary from hypercontractile to the other end of the range with ineffective esophageal motility or even normal peristalsis. So what does that illustration really mean for our patient? Because we've seen that in less than half of them, we may not notice spontaneous resolution of their symptoms before proceeding with any interventional solution for them. So the Chicago classification suggests we run some provocative tests in additional positioning. We want to trigger the deglutitive reserve and run multiple rapid swallow testing or the rapid drink challenge. And for example, in achalasia type 1, we see that no peristalsis has been provoked by our additional testing in this example. And the reasons behind the manometric diagnosis of esophagogastric junction outflow obstruction may be various. There is a great heterogeneity in the literature from structural causes such as benign strictures or inflammatory conditions such as eosinophilic esophagitis, or even medication-related chronic use of opioids or iatrogenic after bariatric surgery conditions. So we have to really identify which of those patients are developing early achalasia or a variant of the disease. So if equivocal in our manometric study, according to high-resolution manometry, the Chicago classification suggests we can run the esophagram or even a planimetry test. planimetry is a really exciting technology that is gaining a lot of attention in the literature, in the clinical practice worldwide. It consists of another type of probe that is connected to 8 or more commonly 16 pairs of electrodes that count and calculate impedance. So the difference in the resistance throughout the esophageal lumen. Now, this probe is connected to a balloon with 16 pairs of electrodes throughout the balloon, and this has the ability to inflate with saline throughout the study. The difference with high resolution manometry is firstly, this needs sedation and is guided through endoscopy. And then the second difference, and even more importantly, is the different principles that planimetry follows. So planimetry would assess the secondary peristalsis, and this is triggered by the distension of the balloon throughout the esophageal lumen, whereas high-resolution manometry, we know that assesses primary peristalsis. The end results based on an endoflip study are the pressure, and this is counted and calculated in this area here with a blue color, the diameter of the esophageal lumen, but even more importantly, the compliance, the stiffness of the esophageal wall, which is a relatively new conception. This is how the endoflip would look like after passing through the junction, and it gives us a lot of information in terms of distensibility in both the lower esophageal sphincter area and the distal esophagus. And this really makes a difference in inconclusive high-resolution manometry or those patients presenting with dysphagia, and a high-resolution manometry conclusive for esophagogastric junction outflow obstruction. So this balloon is connected to a transducer, giving us a lot of information. The horizontal line again is the time axis, and the vertical one represents the impedance. Again, colored in a range, as you can see in this side of the slide. What we focus on when we suspect achalasia is the distensibility in the junctional area. And a proper image you would take would be after applying the Dallas consensus. So the recently presented Dallas consensus requires that we allow at least 30 seconds before we inflate the balloon gradually every 10 millimeters of saline, starting from 20, 30, up to 60 or even 70 mLs. We trigger secondary peristalsis, which we know is quite problematic in achalasia or achalasia-like syndromes. And you can see in the literature that the values that have been published so far are referred to distension from 40 up to 60 mLs. And we have recognized that the threshold for considering an junctional opening to be reduced and limited would be with a distensibility index below 2 and a maximum junctional diameter less than 12 millimeters. And that in some patients may indicate the need for further interventions, especially when the clinical significance is a troublesome and ongoing symptom. And for example, the role of planimetry in this case, which seems to be quite typical to achalasia type 1. However, the numbers do not relate to the typical achalasia type 1 according to the Chicago classification, because you can see absence of peristalsis, borderline IRP, but these do not fall within the strict criteria. So this patient keeps presenting with dysphagia in solid food, and when following the proper steps as suggested by the Chicago classification, we ran a timed barium esophagram and realized that the picture is a rather typical illustration of a bird's beak. And if we go ahead and have the endoflip available in our lab, we would recognize that this patient suffers from limited distensibility in the junctional area, and indeed the index is less than 2 and the diameter less than 12 millimeters. But in other patients with increased intrabolus pressure and the esophagogastric junction outflow obstruction as a final diagnosis in high-resolution manometry, we may have preserved peristalsis, vigorousness in the distal esophagus, and again, limited distensibility index. So this is a rather significant justification before proceeding with dilatations or any other surgical intervention. And there have been studies published that show a significant association between the IRP and the distensibility index in a way of the highest the IRP, the lowest the distensibility in the junctional area. Another study suggesting that the distensibility index may be a more representative way to assess the possibility of treatment failure because the lower esophageal sphincter pressure is not always pathological in patients with recurrent dysphagia after treatment. And last but not least, another evolving field is the assessment of planimetry in the distal esophagus, not only in the junctional area, but also by assessing the contractile response. And there have been patterns that have been recognized as normal or abnormal, diminished or spastic, and we start interpreting achalasia or achalasia variants based on that area in the planimetry test. And what we consider to be a normal contractile response follows the rule of 6, meaning at least six consecutive antegrade contractions, extending at least 6 centimeters in axial length throughout the esophagus, within 6 antegrade contractions per minute as a regular rate. But in achalasia, you see, in planimetry terms, pictures that are similar to high-resolution manometry, such as type 1 with absent contractile response, but also retrograde contractile response signs like in the second or the third picture. And we really end up with a kind of a different algorithm and different definitions based on planimetry, which really shows that we can characterize those patients based on planimetry as spastic or non-spastic achalasia, these two main categories. And a last thing that is a really handy and can prevent patients from unnecessary manometric studies is that during the initial endoscopy, as previously shown, the labs that also have this technology available can perform endoflip in suspected achalasia, and it seems based on studies that more than 80% of patients with normal distensibility index could avoid having unnecessary HRM because indeed this technology offers a high negative predictive value. So that's another thing that planimetry adds. This is an overview of all the subcategories the EndoFlip 300 has offered. And my conclusions are that both tools are very helpful, especially in tricky patients, in troublesome clinical presentations. One does not replace the other. High-resolution manometry investigates the primary peristalsis and the dynamics of the junctional area and the distal esophagus, whereas the endoflip assesses the triggered secondary peristalsis and the biomechanics of the esophageal lumen by evaluating distensibility and compliance. So we want to rely in both technologies when available, And the endoflip does not replace the gold standard that is still the high resolution manometry. However, in borderline manometric tests, it can serve as a surrogate to HRM and act as a smart bougie in the both preoperative and intraoperative setting. So thank you very much for your attention, and I'm happy to take any questions from the audience.
All right, great. If someone wants to, we can even put the question in the chat, or leave it to that. So I had a question about the flip. So if you are in a situation where the manometry is inconclusive or just shows perhaps EGJ outflow obstruction, which is exceedingly common as you showed, would the flip that what would you do with the endoflip? Do you go to endoflip? Do you go into the time barium? Do you do both? How do you manage that patient with the EGJ outflow obstruction in the setting of symptoms? And then sometimes that also comes up in the absence of symptoms. Patients, let's say, get manometry before having anti-reflux surgery, and you get EGJ outflow obstruction. They have a small hiatal hernia, but they don't have dysphagia. How do you deal with those two scenarios?
Yes, thank you very much for those questions. It's really interesting seeing that in the clinical practice, and it's a quite common scenario. But I think you said the magic word, the key word was the symptoms and the assessment of symptoms. So in the presence of symptoms, if I have both imaging and planimetry testing available, I would really want to be justified before proceeding to any endoscopic interventions. Nowadays, we are really reluctant in offering surgical intervention in esophagogastric junction outflow obstruction, and that is mainly because for those units that also have the endoflip, the esoflip, which is the interventional application of the planimetry, is a really nice bridge before final and definitive myotomy. So the endoflip, to answer your question, would be my number one choice when investigating the symptomatic patient. Now, for that patient who happens to have outflow obstruction as an incidental finding during the preoperative setting, I wouldn't go through all the additional testing. I would definitely run the additional positioning, the upright, the supine position in the high resolution manometry, which is not invasive. I would run the additional rapid swallow testing to see whether there is any reservoir in the esophageal body peristalsis or any signs of relaxation of the LES, but I would leave it there. I wouldn't proceed into planimetry testing in the asymptomatic patient.
If I may, that's a great question, Kostas. It's a big problem when you do an HRM for before a fundoplication, and then you get that, and that's a problem. You do a Nissen, or what do you do? Despite the fact that they're asymptomatic or not, the outflow obstruction is a problem. And as Dr. Triadafilou said, you have to see the esophageal reserve with additional testings. If they're okay, I think I would feel okay. But if there are problems and there is no reserve, I would be very reluctant to do a Nissen. There is no data on that, but I would do a partial fundoplication. What do you think, Tanya?
Yeah, I would probably agree. And then the other thing is you want to have more details on the reason why you perform an anti-reflux procedure. Is it the LES? Is it related to a hiatal hernia? Because the esophagogastric outflow obstruction, for example, in some studies has been significantly related to the presence of hiatal hernia. So I want to answer, why am I surgically treating this patient? Is it for anatomic or for functional reasons? But when it comes to ineffective motility, yes, in that case, I'm really reluctant in offering a complete fundoplication.
Yeah, I think we can also have more questions as a group at the end. Let's move to the next one is by Dr. Shaheen Ayazi. Dr. Ayazi is an associate professor of surgery at Drexel University and an esophageal foregut surgeon at Allegheny Health Network in Pittsburgh. He's a director of the Chevalier Jackson Esophageal Research Center and then the Esophageal Physiology Center. He is involved at the SSAT, currently chairs the SSAT Esophageal Subcommittee, and his clinical and research interests are on this topic, exactly motility disorders, GERD, and the evaluation treatment of foregut diseases. So we'll let him discuss Heller myotomy if it's still the gold standard.
Thank you, Dino. I have nothing to disclose. It's a pleasure to join the SSAT Greek and Cypriot chapter today. The question I was asked to answer is that, is Heller myotomy still the gold standard in management of achalasia? Over the past decades, the field of esophageal motility has changed dramatically with the emergence of POEM and advancement in our esophageal physiology tools. But when we examine the data carefully, we realize the answering to this question is not as easy as it sounds. This is actually the appropriate audience to discuss achalasia. The word itself comes from Greek term achalis, meaning achalasia translating to failure of relaxation. Also, early description of dysphagia appears in the writing attributed to Hippocrates, and Galen is the one who described the esophagus as a muscular tube involved in swallowing. Interestingly, although the term comes from Greek literature, achalasia was only introduced to the disease in early of last century and replaced the old term cardiospasm. Once became clear that the problem was not a spasm but failure of relaxation, then the management became easier. So basically it took Greeks to term the disease, but surgeons waited 2,000 years to realize they have to cut the muscle to address the disease. The understanding of the disease ultimately led to one of our most important operations in foregut surgery, Heller myotomy. This is the original description of Heller from his surgery. As you can see, the initial surgery was involved to both anterior and posterior myotomy. But over the time, operation evolved, but the core principle of the surgery remained unchanged, which is relieving the obstruction by dividing the LES muscle fibers. Over the following decades, the procedure continued to evolve, with the key milestone of the disease management surgically are marked in these slides. In 1923, Zager, who was a Dutch surgeon, proposed that we only need to do anterior myotomy. In 60s, door fundoplication was introduced, and it was 10 years later, surgeons started to adding door or two-pair fundoplication to their myotomy. And the era of minimally invasive management of achalasia started in 1991 with Cucciaroni doing the first lap Heller myotomy. 10 years later, Scott Melvin and Aro Darzi did the first robotic assisted laparoscopic Heller myotomy. And almost 10 years later, Professor Ione introduced the concept of POEM. So we talked about that Cucciaroni did the very first Heller myotomy, but addition of the partial fundoplication to lap Heller myotomy was introduced by Dr. Hunter, that we have the privilege of chairing our session today. In his presentation in American Surgical and later on publication in Annals of Surgery, he showed that the rate of reflux improves after addition of a partial fundoplication in terms of either door or toupee. But the necessity of door fundoplication remained somehow controversial till a 2004 randomized control trial from Vandenberg showed significant decrease in the degree of acid exposure after addition of Heller and door, and since then became a standard of the care. The next question that clinicians were asking, which partial fundoplication is superior to others? And there are 3 randomized control trials about this question, and you can see the forest plot of the meta-analysis of these 3 randomized trials. And basically, both the risk of dysphagia after intervention and the degree of acid exposure is similar. So there is no difference between the 2. But to understand where we are today, it helps to remember when we came from. This is a review article from Peter Karlas in 1998. At the time, our options were limited. We had Botox injection that provided only temporary relief but poor durability. Pneumatic dilation was widely used but often required repeat treatment. And the surgical myotomy consistently showed the highest response rates. Even early laparoscopic series were approaching 90% success rate. However, the conversion rate to open was high, close to 5%. What's remarkable is that even before we fully understand the physiology of disease, we already had discovered one of the most durable treatments. But over the past 2 decades, 3 major developments transferred the field of management of achalasia. First was introduction of high-resolution manometry that allows us to understand that achalasia is not a single disease, but a spectrum of disorders. Second, minimally invasive surgery refined Heller myotomy. And third, POEM was introduced as an endoscopic myotomy approach, and we moved towards the concept that achalasia has evolved from a single motility disorder to a spectrum of EGJ outflow disorders that are treated with physiologically oriented therapies. Despite these advancements, the data still supported Heller myotomy to have a very good outcome. There are few meta-analyses that are published in the field of achalasia, and one of them is the campus paper published in Annals of Surgery in 2009 before introduction of POEM. This is a very robust meta-analysis of nearly 100 studies with more than 7,800 patients that they compared the available modality at that time. Heller myotomy achieved the best symptom improvement in nearly 90% of the patients with a Eckhart score of less than 3. But equally important, this study showed that adding a partial fundoplication significantly reduced the reflux with odds ratio of 4. In addition, they showed that Heller myotomy is a very safe procedure with a very rare mortality and a low rate of morbidity. The other landmark meta-analysis in the field are the one that again published in Annals of Surgery, but after introduction of the POEM. And Dr. Paddy's group compared POEM to Heller myotomy in this paper. The very first thing that is noticeable is the follow-up is much shorter in the POEM as a more recent procedure. But the dysphagia improvement was very comparable between the 2 groups. However, one consistent difference across all the studies in this paper is that the higher rate of objective reflux after POEM is interestingly has the same odds ratio of 4.3 compared to Heller door when comparing Heller without addition of the door fundoplication. Another important advantage of Heller myotomy in the literature is the maturity of the available data. There are very few studies that we have such a long-term follow-up with such a large number of patients. This is the largest single-center Heller myotomy series that's coming from Padova in Italy. They have more than 1,000 patients, and they reported their 25-year experience. Their clinical success rate was close to 90%, and in those who had close to 20 years follow-up, more than 80% of them remained symptom-free. Their conversion rate was very low, and the reported rate of abnormal Demister score in post-op pH monitoring to be 9%. They had 10% failure, and they had a very good success with salvaging those using pneumatic dilation. A study also showed that the three predictors of the outcome were sigmoid megacolon megaesophagus that was associated with a poor outcome, manometry pattern in sense that type 2 had the best outcome, and those who presented with pre-op chest pain as their dominant symptom did worse post-operatively. Next, we move to the randomized trial. This is probably the most important randomized trial comparing POEM to Heller myotomy coming from 8 European centers with close to 240 patients that they randomized into two groups of POEM versus Heller DOR. They showed a very comparable symptom resolution. This was designed to be a non-inferiority trial. They also showed that the quality of life is very comparable between the groups. In terms of physiology, we had a very equivalent impact on the reduction of LES residual pressure in both arms. But again, reflux was the concern. Was approximately twice as common after POEM when compared to Heller myotomy and DOR. The same pattern persisted with longer follow-up in this trial that was published in 2025 in Lancet Gastro. At 5 years, symptom outcome remained comparable, but abnormal acid exposure continued to be significantly higher after POEM. So while efficacy may be equivalent, the physiologic consequence in terms of acid exposure are very different. However, complication can be used as a way to utilize one procedure to the other. When you compare the data in several studies, you would realize the complication rate are basically very low in both and comparable between POEM and Heller myotomy with the extremely low mortality rates. So postoperative GERD remains the main differentiating factor. So now that we know reflux is the main factor in our decision-making process, we are going through this paper that was published from our center. More than 180 patients that we were followed for close to 2 years. We had a success rate of more than 90% after POEM in this population. What was interesting was the rate of objective GERD by pH monitoring was more than 50%. And severe GERD, as defined by LAC or D esophagitis or abnormal Demister score greater than 50, was close to 20%. It was also important to note that 24% of the patients who had significant objective GERD had no symptoms. This highlights the need of postoperative testing regardless of patient symptoms. We also found that presence of obesity before the surgery and a low resting pressure of a sphincter predicts GERD after intervention. But technical factors, including myotomy length in POEM, didn't affect the GERD risk. So now the question becomes, how should we choose between these procedures? If we go with guidelines, there are two major guidelines by SAGES and ASGE that basically they recommend for type 2 and type 2 achalasia, both Heller myotomy and POEM perform very well. But for type 3, the guidelines often favors POEM because they believe a longer myotomy can be performed, which is more relevant in the context of a spastic disorder of type 3 achalasia. However, emerging data suggests that a well-performed surgical myotomy may still achieve comparable results in many patients with type 3, and we're going to go through some of those data. Basically, guidelines provide direction in this case, but patient selection and physiology remains critical. This is a paper that just published in Journal of GI Surgery in March issue, and it's coming from Seattle, that they reported their experience with type 3 achalasia who underwent whether POEM or Heller myotomy. They reported a very comparable clinical success, and Eckhart score was also had a very similar decrease and remained comparable post-op. But the rate of multiple reintervention was higher in POEM group, likely in the setting of reflux disease. So basically, there is this emerging concept that achalasia symptoms, even in type 3, are primarily driven by LES obstruction and not just a spastic disorder of the esophageal body, and this might be adequately addressed by a myotomy performed during Heller myotomy, or if POEM is considered, considering a short POEM. How about EGJO that Tanya elegantly described it and discussed about the different findings of it. This is a study from our center. We look at the 52 patients with primary EGJO. These are all the true EGJO that have been confirmed by second modalities such as endoflip or imaging studies. And 35 of them underwent Heller and 17 underwent POEM. The clinical success was very comparable between the two groups. Hospital stay, as expected, was a slightly longer in Heller arm. Impact on physiology of EGJ was very similar degree of drop in IRP, but objective GERD post-procedure was significantly higher in the POEM arm. More importantly was the impact of our myotomy on esophageal physiology. In the Heller group, we had a preserved esophageal body contractility, and we even had an improved bolus clearance on the impedance tracing, whereas in POEM, we had a marked reduction in esophageal body contractility with near complete loss of peristalsis and no improvement in bolus clearance. Basically, both procedure relieved the obstruction and dysphagia. However, POEM was associated with higher reflux and loss of esophageal body physiology. So ultimately, the choice depends on several factors, such as patient comorbidity, reflux risk prior to intervention, prior operation that patient had, the anatomy of the EG junction and esophagus, and most importantly, patient preference. Many patients prefer POEM because it's a less invasive procedure. And this is where a multidisciplinary decision-making process becomes very important. When we look at the national trend, as expected, the number of POEM is increasing and the number of Heller myotomy is decreasing. But also, this data from National Inpatient Sample Database shows that of the all myotomies done surgically between 2015 and 2020, 28% were done robotically. If you look at the numbers, after this period of time, the number is even more favorable robotic. So this is one of the data presented from one of the major thoracic groups that they do lots of Heller myotomy. They did nearly 500 Heller myotomy in 10-year period. And as you can see, the number was primarily laparoscopic at the beginning, but when we got closer to 2016, the trend switched, and now most of the cases are robotic. The other two areas that I'm not going to discuss in details is first comparison of the robotic to laparoscopic for the interest of a time, and the use of endoflip in the intra-op decision-making of Heller myotomy, that we can talk more if there's time at the discussion part. But returning to our question that we started our talk, is Heller myotomy still the gold standard? The data suggests that it remains the benchmark procedure. It provides durable symptom control with decades of follow-up. It offers reliable reflux protection when combined with a partial fundoplication. And randomized trial show efficacy comparable to POEM with substantially less objective reflux. But perhaps the more important message here is that achalasia is no longer a single disease with a single treatment. Modern management requires individualized decision making, integrating physiology, anatomy, and patient factor. So while hilar myotomy remains the benchmark, the best therapy is ultimately the one tailored to individual patients. Before closing, I would like to highlight the upcoming SSAT annual meeting at DDW. Many of the studies that we discussed today were either presented at SSAT sessions or published in our society journal, the Journal of GI Surgery. If you look closely, you will see JOGs referenced in many of my slides. We have several excellent esophageal motility sessions this year, and I want to acknowledge help of Liana that helped us secure these sessions. So basically, we have 3 main symposium and also individual podium abstract session in addition to the talks that would be distributed among other sessions. So I hope I see you all in DW. Thank you very much.
Rahim, great talk. Let's save questions for the end. We'll move on with because there's one question that already on the Q&A. I think you may have answered that already. If there's other questions, please put them there, but we'll discuss as a group. The next and final presentation before we open it for a group discussion is from Dr. Onur Kotlu. Dr. Kotlu is Associate Professor of Surgery at the Miami School of Medicine, Director of Bariatric Surgery and Metabolic Health Program. He's the co-director of the Pancreas Center and Total Pancreatectomy and Islet Transplant Center there. He's also the current president for the American Society of Metabolic and Bariatric Surgery for Florida, Puerto Rico, and the Caribbean chapter, and he co-chairs the Esophageal Committee. As we'll see, he does a mix of upper GI surgery that includes achalasia. So he will talk to us, but of a bit of a spin in a treatment for achalasia for certain patients.
Can you see my screen?
Yes.
Okay. First of all, thank you very much for including me in this. It's so hard to speak in front of such a distinguished faculty and the audience here. I'm a recovering HPV surgeon. After I stopped doing cancers, I found my new life in benign foregut and pancreas practice, and I greatly enjoy this. So I would like to speak about a different topic that's not done very often for achalasia, which is minimally invasive esophagogastrostomy as a salvage procedure in end-stage achalasia. So 1 second. So I have no disclosures. We often get these patients with an awful esophagus, and they're frequently referred to us for esophagectomy. The issue with that is it's a morbid operation. Even in patients who don't have this humongous mega esophagus, it's a significantly morbid procedure. Many patients don't want to get the operation done. And yes, it's something we do routinely as foregut surgeons, but also a lot of people don't like dealing with esophagectomies. Usually in the end-stage achalasia, where other matters have failed, other ways of treatment has failed, the esophagectomy is the last option. However, for a long time, people tried to find an alternative ways of treating this without esophagectomy. So a couple of operations have been described in the past. One is a Cervidoria operation. It's basically a variant of what we do in the patients with end-stage achalasia sometimes. It's a wide open cardioesophageal anastomosis. But due to the concerns of reflux in these patients, in the past, they've tried doing a Roux-en-Y gastrojejunostomy. In some instances, they were doing a distal gastrectomy. I will get to why I don't like doing this, because I want to have the stomach as a conduit if I have to do an esophagectomy in the future, and I like to leave the stomach as undisturbed as possible. The other operation, Hakafuku operation, it's basically a Heineken-Michelitz stricturoplasty for the GE junction in these cases. Another option is to perform just the esophagastrostomy part of the previous Heradoria operation as a less invasive step before esophagectomy. Because with this procedure, you have a wide site-to-site anastomosis, less risk of persisting stenosis. You're going to see that you have a very wide anastomosis in these. It's much less invasive than esophagectomy, and there is no change in anatomy. If you want to do esophagectomy in the future, it really is. There's not much of a challenge to do after these operations. Usually these patients that come to us that have a previous palm and then they get a Heller and then they fail, they come with humongous esophagi. I'm going to show a video of this, but like step by step, you basically need to straighten out the esophagus and pull it down, which has been described in other procedures also, suturing the esophagus to the crura after doing a very high dissection. And we suture the fundus to the side of the esophagus. I like to leave a fat pad here or a piece of the hernia sac to use as a handle. And then do a gastrotomy. It's very hard to put an instrument through the GE junction. It's usually very tight, like you see here. So most of the time, I have an assistant doing an endoscopy that puts a CRE balloon through there and dilates it so I can place a stapler through there from the inside. And then you do site-to-site anastomosis. It always takes 2 fires. 1 fire is not enough. It's just the first one just gives you enough of an opening, just a bit, but the second one gives you the opening that you want. And I usually close the second layer and the anterior part over a 50 French bougie. And suture the esophagus to the crura at 4 different points to wishful thinking that it will not go back up, but invariably all of them you see the esophagus being retracted a little bit. And at the end, you see a big opening here, which is around like 2.5 centimeters or so. Everything goes down fine. And when you do retroflexion, you see this big anastomosis here, but the edges act like a flap, and these patients, in fact, don't complain of too much reflux, but they all stay on Reglan too. So this is a story of a patient. This was something that I presented at the SFAT. This is a 56-year-old female. She had a myotomy 3 years ago. First gets a palm, then gets a myotomy, recurrent progressive dysphagia. She loses a lot of weight. They place a PEG tube in her for malnutrition. And she came to me with megaesophagus, a peristalsis. She doesn't want an esophagectomy. That's what she did. That's why she was sent to me. So this is how the endoscopy looked like previously. This is a humongous. She had a humongous esophagus, like most of these patients. These are my port placements. The important thing that I found when I do these cases is to place the camera port slightly offset to the midline, to the left side, because in fact the esophagus is like a sigmoid shape up here. If you place the port in the epigastrium, it's hard to see. I like to dissect up to the level of the azygos vein. It's much easier if you offset the port a little bit to the left side of the patient. And then, so we start by taking down the adhesions in the previous PEG tube site. And these patients, you see that she has a big hiatal hernia also, everything is pulled down. I always start by taking down the left crura because I don't want to go there again. I leave just a little bit of flimsy tissue before my dissection on the right side. And then on the right side, there's always this vein or lymph node that marks the end of the hiatus. I use that as a landmark and I go up and I do my entire dissection from the right side. And because I've cleared up the left side of the patient, it's very easy to open it up. There's just filmy stuff. You don't have to do much dissection. You just pull up and it just opens up. Later, I go up high in the chest as much as I can. You see how big the esophagus is here. You want that to back inside the abdomen. And these patients, in fact, have a very long esophagus because of the dilation. And this is how high you go up. You're up to the level of thoracic inlet, just like you're doing an esophagectomy. If you don't go up this much, it's very hard to gain that length. and later pull the esophagus back inside the abdomen, go up to the azygos on the right side to have a little bit of more length in this patient. I had to do that, and then I take down the short gastric vessels and I suture the esophagus. Sorry, I usually Vicryl to pull the esophagus down and mark the GE junction. And then I suture the esophagus to the crura at 2 different points initially to make sure that stays in place when I'm doing my stapling. This is just simple suturing. I use non-absorbable sutures because of the video. It looks blue, but it's in fact a green Ethibond suture. Because this patient had 2 different procedures in the past, it looks like looks like a dog chewed on it, but it's not as bad as it looks. Again, I leave this little piece of hernia sac there to able to manipulate the esophagus. And I first do the posterior layer suture. You have to do the posterior layer suture first. Initially, I tried to do the stapling and then suturing later. The reason is the stapler just slides out. You can't get the fundus to hold in place when you're fired or staples. So after this, I open the stomach. Again, the thing is, the GE junction is so tight in these patients. It's very hard to pass the staple through there. You can't even pass the instrument. This is after a dilation with a Seary balloon was done intraoperatively. The fellow just did the Seary dilation. And then I fired the stapler twice. The first one gives you a small opening, but the second one completes it. I found this to be the easiest way to do it, and when you look inside, you see this big wide opening between the esophagus and the stomach. Again, we close the stomach with a standard stapling. I like to preserve the vagus for style points. I don't know if it makes a difference or not. The reason is we do vagotomies in people with intractable, ulcers or gastric bypasses or esophagectomies. But I try to preserve it as much as I can if I could. And then I land with the anterior layer. I believe that it creates some sort of a flat valve there that helps them with their reflux. This way, I don't have to manipulate the stomach. I'm gonna then at the end of the case, I don't do an endoflip on these guys because the endoflip balloon is not wide enough to give me any information on this. After this, the esophagus is also sutured to the anterior with a 2 Ethibond suture. I fix the crura to the fundus again with 2 Ethibond sutures, non-absorbable stitches to keep everything inside the abdomen. I don't close the crura completely, but I close it somehow because in one of the cases, the small bowel went into the chest, and I again fix the esophagus at 4 points to the crura with non-absorbable sutures. This way, I try to keep as much of it as I can inside the abdomen. So this patient, we just saw her in the clinic. I got to repeat news endoscopy. This is the intraoperative endoscopy over with the wide opening at the GE junction now. So we did 10 after these. We do upper GI series on day 1 on drain amylase. We start them on clear liquid diets, remove the drain after, and then they usually go home on the 3rd day. The most important point, I believe this is you should dissect the esophagus as high as you can. It makes your esophagectomy harder, but it's good practice to do that. I believe you fix the esophagus to the hiatus at 4 different points to prevent again this esophagus from sliding up. I like to do the anastomosis posterior laterally, and I preserve the vasculature obviously to help me in my future esophagectomy if I need to. So this patient came back She had some dysphagia issues, and this is a repeat endoscopy that she had. This was when was this? Yeah, the 2nd of March, 8 days ago. You see, there's a huge opening here. The anastomosis is still wide and patent, and then you retroflex this. You see the anastomosis that it was done, and she was doing pretty well. The reason I do this is, think about this, like you want to do an esophagectomy, all you have to do is you just fire a stapler through here and you have a very long gastric conduit. I had to convert one of these patients to an esophagectomy later. It was harder. Normally I like to do the anastomosis in the chest. I don't like to dissect up here. I'm not very good at that. Maybe I'm too scared to do it. Um, However, in these cases, the esophagus is very dilated. You cannot do the anastomosis, or it's hard to do the anastomosis in the chest anyway. And I have to do a 3-compartment esophagectomy on this patient because there was a lot of inflammation on the inside the mediastinum. I do a lot of hiatal hernia repairs on patients who have lung transplants. Their chest is not as inflamed as these guys. So they're easier to do. So we don't have much data on this in the literature, but we know from Pseudoria operation, which is a Roux-en-Y version of this, there's a lot there's significant symptom improvement on these patients. Conversion rates for these operations for esophagectomy in some series it's up to 30%. In our groups, these are the complications that we had. So I had 2 GI bleeds. They had to go under endoscopy and clipping of these. Interestingly, you have a very thick muscle there, and you think that the white load is going to crunch through the tissues. In fact, I found after I switched to white loads, in the other cases we did not have GI bleeds. But 4 of these cases that I used blue loads, I had half of them had GI bleed. One of the patients, I did an esophagectomy at 3 years. I had to go up. I had to do a 3-compartment for these, and 2 patients underwent dilatation. So these were my outcomes. There's not many case series about this. These are sporadic case reports. But in patients who do not want to undergo esophagectomy or who did this may be a salvage procedure before we go further with procedures. And this is another patient. I couldn't find a way to dump the CT scan, but this patient had a CT scan done 1 year after surgery. Let me just show you. I just pulled it up here. 1 second. And that mega esophagus looks just like this. This is the esophagus. And after the procedure, they still have esophagitis. The esophageal wall is thick, but they feel much better, and they're tolerating their diet. Their weight loss has stopped. So this is what I would like to talk about in this this meeting. Thank you very much for your time, and we invite everyone again to DDW, to our sessions. It's great talking to such a distinguished group of colleagues. Thank you.
All right. These were great. So I'm sure I saw a hand. I don't know if I see it anymore. Someone had raised a hand for a question, but I don't see it up anymore. I think in terms of there's 3 questions in the chat. So the first question says, given the high reported rates of postoperative reflux after POEM, how do you balance the risk between POEM and Heller? So I don't know. Maybe we can ask Shaheen's opinion on this, and Dr. Hunter has a lot of experience in the field. I'd like to get his take on that too.
So if I see a patient has a high risk profile for developing reflux after myotomy, I prefer to do Heller myotomy for them. And those risk factors are hiatal hernia, obesity. If a patient is not type 1 and 2, I always do pH monitoring before, because often patients with EGJ or type 2, they may already have reflux disease. So those are not the patients that I would offer POEM to them. So that's my decision-making process.
Maybe I'll jump in here and just sort of talk about how I think about it. First of all, I think these were three superb talks, and I have comments on probably all three of them. But since we're talking about POEM versus Heller at this point, I generally present both options to patients, and again, I think it's actually also present balloon dilation to them. I present Botox, so they are aware of all the different treatments that are out there. But then they usually say, "Well, doc, what would you do if it was yourself or your family member?" And for the type 1s and type 2s, because of this reflux question, but also because of the ability to increase the diameter of the LES much more with a Heller. I think when you measure the diameter of the LES after a well-done Heller, you've doubled it. And I have not seen the same measurements with the POEM, but I doubt you double it, because it's the undermining that you can achieve with a Heller that you cannot achieve with a POEM. Now, there's a certain amount when you use a dilator, use a balloon or something, that there will be some sort of blunt undermining that will occur, but it's nothing like you can achieve with a Heller. So for type 1 and type 2s, that is my favorite approach. And type 3s, because you can't get high enough to divide all the muscle, I still steer them towards a POEM. Now, I do like this theory about sort of, does the residual high pressure zone above the myotomy recede once you've done a Heller? And for years and years, we didn't have POEM, and we did Hellers on type 3s. And for the most part, it worked. But I probably had a handful of patients, and I'm just going to guess that it was 10 to 20% who maintained high pressure zones above the Heller and developed post-op dysphagia. In those patients, we've gone back on them and used manometrically guided POEMs. In other words, you measure exactly where the high pressure zone is, you enter above it, exit below it, or not exit, but finish your POEM below it, and that has resolved their dysphagia. So you could certainly use the Heller as your first approach to type 3s, and then selectively go back and do salvage POEMs, if you will, on those who have residual disease. So it's sort of trading, perhaps the need to do a salvage POEM versus the likelihood of reflux if you did the POEM as your only procedure. So I think this so you could choose either approach, although I still think type 3s I would treat with POEM at this point. I think just a couple of other comments about the Heller, and then I'll shut up for a bit. The things that haven't been discussed that are really critical is the blown out myotomy, and that can occur with either a Heller or a POEM if you leave a lot of myotomized segment above the diaphragm, especially if you don't completely ablate the LES. But even if you do completely ablate the LES with a good Heller, I think it's really important to try to leave your myotomy below the diaphragm. And so when we suture the door, we do try to include that top end of your myotomy, suturing it to the diaphragm so that the whole myotomy stays below the diaphragm. That's really my only sort of technical point I wanted to bring up. But thank you for the opportunity to comment. And great talk.
This was a great insight. The next question is, what do we think is the optimal treatment for elderly achalasia patients? Elderly is a moving target. That's like a definition that is very funny. But Dr. Theodore, what do you think? Let's call it 75 or 80. You're muted. Sorry.
Well, these were great talks. Thank you all. And of course, there is a lot of discussion could be done. I think octogenarians, we mean at the 80s, and we do know that there is a second curve of achalasia happening at that age group. What I would do is I would suggest a dilatation first. And if dilatation does not work, then they either fit for surgery or POEM. And I think that the risk is the same. I mean, it's general anesthesia, complications, everything is the same. So of course, the patient at the end decides what to do. But it depends on the general condition, and I would like to start with dilatations first. What do you think, Dr. Ayasi?
So first of all, I agree with you about rate of achalasia in elderly. We see even seeing an increased surge of octogenarian with achalasia that some people contributed to the COVID. They are saying that COVID may impact the meningeal nerve plexus similar way. But I usually offer POEM to that group, unless it's a very physiologically fit patient that I discuss with them about Heller myotomy. And there's also a group of elderly that all I can offer them is pneumatic dilation.
Very good. And then the next question, this is the one about, it talks about long-term developing symptoms after POEM, especially, and I'm assuming this is about GERD symptoms. And especially because those symptoms are often silent, like you don't even know, like esophagitis can be pretty common. They don't even know they have symptoms because their esophagus is not really functional. So these patients need to go to a surveillance program, or at least that's what we do here. They go to a surveillance program. So after POEM, so if someone is 25 versus 75, that almost gives them like a 50-year, you have someone who's 25 years old, it gives them a 50 years plan of you're going to be monitored with endoscopies all the time as if you have Barrett's. So do you factor age at all in that decision making?
So I think they're also asking about, is this failure of myotomy or reflux-driven symptoms? One thing to consider when you're looking at the literature of POEM is data is not as mature. The very first POEM was presented by Ione in 2012 in DDW, whereas for Heller myotomy, we have more than 100 years of data. So we don't have much of long-term symptom data with the POEM, but I agree with you about monitoring the POEM patients. For all of my POEM, I bring them back every year to scope them, do a pH monitoring if needed. Because achalasia patients have what we call it actually hyposensitivity. They are not sensing symptom as much as the average population would sense.
So would you dare say that the only advantage of POEM is aesthetic?
It's hard to say. The thing is, patients always prefer a non-invasive approach.
Wow.
And there are patients that they do very well with POEM, and reflux can be controlled with medication in that population. It's just they need to be a little bit closely monitored.
Yeah, I mean, a lot of the anecdotal is like market control, right? So for the most part is when someone has achalasia or someone has dysphagia, where do they start their evaluation? And oftentimes this could be a gastroenterologist, and then from there on, they can be steered differently. So I think regional and local market control has a huge impact in this. Dr. Hunter?
Yeah, I was just going to again, great discussion. Just add one other thing. I did touch on it just a minute ago, which is a failure of poem is not just reflux. The failure of poem is the blown out myotomy, which is to say that more and more the long-term issue is this sort of high pressure zone above the diaphragm that with a weakness in the muscle created surgically with a poem now blows out, and really at that point you have no other option other than esophagectomy, so it is a concern that we'll have to follow over the years to determine whether the GI folks when you talk to Mike John Pandolfino or some of the others who have been sort of the champions of poem they're beginning to see more and more of these, and they have great concerns about them.
And even when you see in the GI literature, they are moving away from long myotomy. They are advocating for shorter myotomies.
So interestingly, in the last year, I had referred three patients referred to me because they had abnormally long poems. I don't know if there's some standard that they're following or not, but you see this 15 centimeters poems starting from the top of just below the thoracic inlet. And these patients who previously had achalasia now completely aperistaltic esophagus. And there's not much that you can offer to those people. It's a very dramatic thing. And in fact, one of them was a physician. And I guess the long poem should be avoided, and there should be some sort of standards for this.
There is a tendency to use the end of lip during the procedure so they can tailor the myotomy. They don't do more than they need, as we do in surgery sometimes too. But I think the patients have to be informed. That's the problem. And it has to be an MDT. Really, like there is MDTs for oncologic patients, this is an MDT that the patient has to take all things into consideration. And I know the GIs people say, okay, well, he got a little reflux, he can take some medications. If you are 30 years old, that's not fun. I mean, it's you are taking a very serious long-term problem. Even so, the high rate of reflux for our population, I don't have a single patient at the young age, or up to 20s, 30s, that elected to have a poem. I don't even have one.
Well, we're right at the end of the 3:30. I think this was a great discussion. I want to thank everyone for taking the time and putting their thoughts together and having this discussion. It was really very informative, and this was a really exciting part to be the inaugural, I guess, webinar for the newly formed Greek and Cypriot chapter. And kudos to the entire passionate GI surgeons in Greece for putting this together. Again, I want to thank
you for your contribution. Thank you all.
Yeah, no, that is a great session, and I would love to see this session at the SSAT. So bring it to Chicago.
Noted.
Okay. All right.
Have a great day, everyone.
Many thanks.
Bye. Thank you.